Welcome, everyone. Can you hear me okay? It's a problem with being tall. Microphone's down here. My name is Eric Borwinkle, and I have the distinct honor of serving as the Dean of the UTHealth School of Public Health. And I also have the great honor of kicking off today's celebration, really. So it's with great pleasure that I welcome you, first of all, and thank you for being here, to the annual John P. McGovern Award Lecture Series in Health Promotion. So on behalf of the UTHealth Houston School of Public Health, I want to congratulate Dr. Amelie Ramirez on receipt of this year's award. Dr. Ramirez has been a friend of the School of Public Health and our campuses for decades, and it's especially as it relates to cancer screening and prevention in Hispanics, which will be the topic of her discussion today. The annual John P. McGovern Award Lecture Series in Health Promotion was established in 1996 by Dr. McGovern to acknowledge the important role that health promotion plays in public health. Each year, we honor researchers and community leaders who have made invaluable contributions to health promotion and to prevention. Dr. McGovern was a distinguished American and an internationally known physician who was lauded by numerous professional societies and governmental agencies, universities, and other countries for his significant medical and scientific contributions, as well as for his leadership in both education, research, particularly in professional writing, his own writing and writing skills by those of us who are here for just an example. This foundation has long supported UTHealth Houston, and today's award represents his commitment to the important field of health promotion. I would also like to thank Dr. Maria Fernandez and the Center for Health Promotion and Prevention Research for their stewardship of this award. CHPPR, as it's known locally, was founded in 1982 with a mission to conduct research, to develop, evaluate, and disseminate health research to develop and disease prevention programs, diverse settings, and in populations. Some 40 years later, and with the leadership of Dr. Fernandez, the center is thriving with multidisciplinary environment, multidisciplinary research with investigators drawn from all of the departments within the UTHealth School of Public Health here in Houston and across the state. So at this time, I'd like to welcome Dr. Fernandez to the podium to introduce today's distinguished lecturer. Maria? And I just messed up her speech.
No, not at all. Thank you so much, Dean Borwinkle. We really appreciate, first of all, your leadership at the School of Public Health and also taking time from your very busy schedule to join us for today's lecture. So hello, everyone. I'm Maria Fernandez. I'm Vice President of Population Health and Implementation Science at UTHealth Houston. And it's my honor to be the director of the Center for Health Promotion and Prevention Research. Today, it's my distinct honor to welcome and to introduce Dr. Amelie Ramirez, who has been selected by our faculty of the Center for Health Promotion and Prevention Research as a 2024 McGovern awardee. If you all got those booklets, and also for those of you online, you'll see the many distinguished scholars who have been awarded this, including Albert Bandura, who I think you would be counted as the granddaughter, academic granddaughter of Dr. Bandura. So it's particularly an honor for me to welcome Amelie, because in the late 80s and early 90s, she was a faculty member within our School of Public Health, and she was a faculty member at the Center for Health Promotion and Prevention Research. She is an internationally recognized cancer and chronic disease, health disparities, and health promotion researcher. She's the chair and professor of population health sciences at UTHealth San Antonio and the founding director of the Institute for Health Promotion Research. She's also the associate director of cancer outreach and engagement at the Mays Cancer Center at UTHealth San Antonio. And over the past 30 years, Dr. Ramirez has directed over 100 research programs focused on human and organizational communication to reduce chronic disease and cancer health disparities affecting Latinos and other minority and underserved populations. This has included a focus on cancer risk factors, clinical trial recruitment, patient navigation, tobacco prevention, obesity prevention, and more. Dr. Ramirez has authored many peer-reviewed articles, is an editorial board member on several prestigious journals, and is frequently invited to speak at scientific meetings. She's been widely recognized for her work to improve Latino health and advance Latinos in medicine, public health, and behavioral sciences across the United States. Dr. Ramirez is on the San Antonio Mayor's Fitness Council and the former board president of the Academy of Medicine, Engineering, and Science of Texas. Dr. Ramirez is a native of Laredo, Texas, and she received her MPH and her DRPH degrees from our own UTHealth School of Public Health. On a personal note, it's such an honor for me to be part of today's events and to introduce Dr. Ramirez because she's always served as an inspiration to me. In fact, over 25 years ago, when I was being recruited as a postdoc to UT Health, and I was talking to Dr. Alfred McAllister, one of Amelie's mentors, when he mentioned that I would have the possibility of working with Amelie Ramirez, that was really the deciding factor for me. Already then, she was well known in the US and abroad for her impact on Latino health. And I know that I'm not alone in the many, both Latino and other scholars and health promotion advocates who've been inspired and influenced by her body of work. And also, and I think you'll hear it today, her passion for improving equity for Latinos. We're so excited to have you here, Dr. Ramirez, and I am going to present the award to you. Please help me in welcoming her and congratulating her for the John P. McGovern 2024 award.
Yes, it's beautiful, beautiful. Oh my God, thank you so much. Maybe just put it right over here.
Sure.
Well, thank you, everybody, for making time to be here, and Dr. Moorwinkle, thank you so much, and Dr. Fernandez for this opportunity. And I'm very humbled. Most of all, because it's coming from my own institution where I spent a lot of wonderful time, and I, again, extremely grateful for having selected me. Gotta turn this little thing on. Today's presentation is just kind of a compilation of different things that I have worked on, and as Dr. Fernandez said, it really has been a passion for me to do the work that I'm doing now. And I'm very grateful for the wonderful faculty that the school has. And Dr. Mullen has also been just an amazing mentor to me. And you'll learn a little bit about Alfred in just a moment, but he also really made an instrumental difference in me. So for those of you who are postdocs, who are students, really look for those individuals that connect with you and who want your interest at heart to help you figure out which direction you want to go in your future, because it truly does make a difference. It did make a difference for me. So the title of my presentation is Shining a Light on the Latino Population to Build Health Equity. I'd like to first start off with a story of a young woman that we met in San Antonio. Her name is Amber Lopez. At the age of 14, she was a normal teenager getting ready to transition from middle to high school and just learning all the ropes. She lived with her mother and two sisters. But suddenly she started to have some very severe pelvic symptoms and was in severe pain and was having extensive pelvic bleeding and didn't know what was going on. So she went to go see the doctor. But when she shared these symptoms with the doctor did not really pay quite a bit of attention to her. He said, "You're too young. It's just a normal transition. You're transitioning into womanhood. You'll be fine." Well, later, at age 18, Amber came back. And this time her symptoms were worse, and she was diagnosed with cervical cancer at the age of 19. She said that when she heard those words, she said, "What's going to happen to me? Am I going to die?" She didn't know anybody her age that had been given this diagnosis. And she went through some, as we women know, some horrible tests that obviously were needed to diagnose her and to treat her. But this left her with a lot of ill feelings about medicine in general and just trying to better understand what was going on in her life. Now, at the age of 26, Amber is a cancer survivor. She got married, she has a daughter, but she still has a lot of recall memories of what her journey was like. And she wants to now to try to make a difference. She ended up having a partial hysterectomy, but is always concerned, will my cancer come back? Amber is one of the many unheard and unseen Latinos. She deserves to be seen and heard. And that's why my team invited her to give her an opportunity to share her story so that perhaps she could make a difference for others. On the next slide, you'll see hear directly from Amber.
Wanting to get my story out there and just kind of be an advocate for someone like that could be as possibly as young as I was when everything happened, or even younger, you know, definitely giving that insight, because I mean, I didn't have that.
So we need to do a better job in listening and hearing to our community members about what are they truly seeing, feeling, and what are those concerns that they have. You know, right now, 2 out of every 10 individuals is Hispanic or Latino. That's 20% of the US population. But again, we kind of go unrecognized and unheard. And my question's always been, why are we so invisible? Now I'd like to take you through a journey of another little boy. And this is Ernesto, lives with his family in San Antonio. He's only 4 years old. And so, you know, in the next few slides, I want to put yourself in Ernesto's shoes and think of going through what his family goes through each and every day as they face some of these adverse events that are happening to our communities every day. First up is poverty. Poverty is very high in our community. 1 in 3 Latino families live in poverty. His parents work long hours at a restaurant, but are still barely making ends meet. Support isn't around. The family doesn't have health insurance, so if they need to go for any kind of medical care, they end up at the ER. Also, Ernesto doesn't have access to pre-K programs in his neighborhood. You know, he's usually left with a relative or a neighbor while the parents work. Already, he will be at a disadvantage when he enters kindergarten. And his family spends most of their income on just trying to keep a roof over their heads. Rental incomes have gotten so expensive that, you know, all they can do is pay for the rent and the utilities. The home is somewhat far from where the parents work, so they have to rely on public transportation to get where they need to go. But oftentimes that means transferring several buses, keeping them away from their family for even longer hours than that they would like. And they live in a neighborhood that's not easy accessible to a large grocery store, therefore having lack access to fresh fruits and vegetables. But there are a lot of convenience restaurants, fast food restaurants, or they have to shop at a local convenience store for some of their foods. And then if he wants to have a place to play, but there's not many places to play near his home. The sidewalks are broken, there's loose animals, and usually the school playgrounds are closed after hours and on weekends. Ernesto's family's home sits on a major intersection where there's a lot of vehicles going back and forth, releasing a lot of fumes. And then even some of Ernesto's family members work at small farms that are just outside of the San Antonio area, who knows what pesticides they've been using out in the farms where they work. And then there's just, because of the poverty alone, Ernesto's family is constantly under stress. And just, for day-to-day living of pressures of how to make ends meet and suffering from mental and physical anguish. Ernesto's parents are also concerned with the political climate in terms of anti-immigrant climate that we're facing. There's a lack of social cohesion, lack of moral disengagement, and just, concerns about what will happen if one of them gets deported. Mom was born and raised in San Antonio, so she's a citizen. But all of this is on top of their mind. So what does this truly mean for Ernesto and his family? It means that this is putting him at higher risk for all the risk factors that we as public health professionals are trying to reduce and prevent. It puts him at a higher risk for obesity. Already our Latino community has over 40% rates of being overweight or obese. For our children, it's already 20%. And some say that our children will not outlive their parents because they're carrying this risk and developing chronic disease at a much earlier stage. Look at diabetes. 40% of our population has a chance of developing type 2 diabetes. And more concerning is Alzheimer's. Already, our Latino population is 1.5 times more likely to develop Alzheimer's. And heart disease is not far behind. We still have a lot of issues with high blood pressure, high cholesterol, all of those issues that are related to cardiovascular disease. So just think of all of these, disparities that have been placed on him and already placing him at a higher risk. And then when you map this out, we've been talking about mapping, you overlap all of these chronic diseases and you see them extremely strong in South Texas compared to the rest of Texas. I've spent a lot of time in cancer, and so I'm really looking closely at the rates of cancer. There's expected to be a 142% increase in cancer among Latinos by 2030. These are the latest ACS cancer figures for Hispanics in cancer. We see the typical priority cancers, but when you look at some of the areas where we see greater disparities, it's really those that are associated with infectious diseases such as cervical cancer, stomach cancer, and others. And these are some of the things that we're beginning to track a little closer because they're inching up. These are just the national statistics here, but cancer before COVID was the top killer among Latinos, and breast cancer was the top killer for Hispanic women. After COVID, now we're back at the same, and it's not a race, but we're at the same level now with cardiovascular disease. But as you can see, these levels, they're not all going straight down. They're ticking up just a little bit in some of the areas. Particularly liver cancer is something we're concerned about, and nationwide. We've seen differences here in South Texas compared to Texas and compared to the nation for Hispanics. So these are tough statistics to think about. And earlier in meeting with some of the faculty, and said, how do we go about truly changing this and making a difference, not only for an individual, but for a larger population, and really helping our community to be seen. And for me, this started back, I'm from Laredo. It's a small border town with a high percentage of poverty, almost one of the most impoverished counties in the United States, about 20 to 25%. But yet at the same time, we were 95% Latino or Hispanics as I grew up in that community. I was one of 5 children of Filiberto and Saida Gutierrez, and we grew up, my dad having 2 jobs, his regular job and then managing the ranch that was inherited from my grandmother. And that's where we spent most of our weekends, is really just helping my dad and my brothers out and running the ranch. What I noticed in growing up, it was why was everybody waiting until they were so sick before they went to see a doctor? I just didn't understand how to get over that, some of that cultural waiting until they were so sick that then they said, everybody said, okay, our final alternative is to go see a doctor. But I think it's because we weren't feeling seen or heard, even in a community with as large as ours, with such a large Hispanic population. My father lost his own dad at the age of 9. He was one of 9 siblings in the family. His brothers and sisters, some of them that were older than him, got to go off to college, but he stayed back to help his mother run the ranch and a small business that she had. But so again, even within our family, sometimes we're not even listening to our own children. He wanted to go, but he felt the responsibility of staying back and helping his mother. When they first married, my dad volunteered for the military, and his first assignment actually was here in Houston, and he was given a job as an orderly in a hospital. And the patient asked him, "Oh, you're doing such a good job. You must really like what you're doing." And my dad told him, "I don't really like my job, sir, but if I were in your shoes, I would hope someone would treat me the same." My dad made sure that he brought him a hot cup of coffee in the morning and that his breakfast was warm. And the patient took the time to listen and to hear him. And he says, "Well, what would you really like to do?" He said, "What I'd like to have a trade, learn something that I can use to support my family in the future, like work on airplanes." This is my dad, the second one to the left on the front row there, where he got his dream of being able to become an aircraft mechanic. Also in high school, I was, so my parents were always extremely supportive. Education was said, this is your route, this is what you need to do. My science teacher in high school was also very instrumental. Mrs. Magnon, she even got a building named after her. But if it wouldn't have been for her, a number of students wouldn't have thought to go on to college and to do other things. So I wasn't clear what I wanted to do in college, so I came here to U of H. I majored in psychology. I just knew I liked to help people. And I said, okay, that sounds like a great opportunity. So I did that. This was with my roommate here at U of H. And then, and I started thinking about that. And I said, when I was done, I said, what am I going to do now? Who am I going to be representing? And I thought it was really important to take you all through a little historical journey of to saying, how long have Latinos been here in the United States? And we really represent a mosaic of cultures. And I'll share with you why the term Hispanic has changed over the years in just a moment. But we've been here since the 1400s. So again, my question is, why are we not being listened to and heard? I mean, we were up front. Puerto Rico was one of the first US settlements back in 1521. And you hear some of the negative rhetoric that goes on towards Puerto Rico. We have to change that. We have to come together to truly want to make a difference and help everyone. What about the terms? The terms, we weren't even really classified until maybe 1930, where we were called Mexican. And then, finally in the 60s, we began to see a change due to the civil rights movement and saying, no, we need to be acknowledged. We need to know so that we can come together and perhaps, ask and get additional appropriations that could come to our community. So in the 70s is where between the 70s and 80s was the first rise of a Hispanic term, but it was a government term. It was a term given to us. And then, in between the 80s, 90s, and 2000, we began to see a shift to Latinos. And when I first started in this work and meeting colleagues from the East and West Coast, they used to say, no, we're Latinos. And I'm going, well, I'm Hispanic. I grew up in South Texas. That's what they call me, and we used to have a discussion about what those terms were. And so Latinos really was more a way of embracing some of the shared European colonization that was going on, because Latinos, we represent everything from European to Central African to Native American. We're all in there. And as DNA becomes more important for future drug development, we need to know more about these, our ancestry. And then now, right, what are we? You know, it's Latinx, Latin, are new terms that are being thrown out. Some of these is because they felt that Latino was too gender specific, that it was not inclusive, but in the language, the official language, it is inclusive of men and women. And so these have become more like broadcast terms using Latinx and Latin. And overall, Hispanic is still the preferred term. And that's what, when you're writing a grant, you're always having to decide what term am I going to use? And you need to define it, right? Because NIH and others are still using the term Hispanic. But as you can see here with these different assessments that, you know, Hispanics is still widely used, but more and more people are beginning to feel more comfortable saying where they were originally from or where their parents are originally from. This pie chart here shows the diversity of Latinos, you know, with, again, Mexican Americans having the highest percentage here in the United States, followed by Puerto Ricans, and then smaller numbers of each of our groups. But we're realizing that we need, and we don't have studies to look at all our different groups. There's discussions and debates. Is it better to look at us as one big group, or is it okay to begin looking at the similarities and differences among our population? So this is where really I began to say, you know what? I need to do something. I need to be able to speak up and talk about my community and begin looking at how we can have better health opportunities for our community. So my first job here was to work at Baylor College of Medicine with the DeBakey Heart Center. And that's really where I developed my skills in health communications. And even though we focused more on cardiovascular disease, my colleagues and I were assigned to work in the navigation area and to talk about high blood pressure. And we came up with something that was called el asesino silencioso, the silent killer, and to help explain the number. And even now I ask, do our patients know their number for high blood pressure? Most of them don't. And Dr. Mullen, you remember back in the day, I mean, this was a big push for NHLBI. I really wanted people to know their number to make a difference. So part of it is that our educational and our awareness about what we can do to reduce our risk factors wanes. We don't have steady funding in terms of really talking about preventative risk factors. That led me to do some work here at Baylor to do the first randomized study on weight reduction among Latinos. It was called Cuidando Su Corazón, but that study gave me an opportunity to be on national committees at NIH on minorities. And that's kind of when some of the original work to saying, hey, we need to look at everybody, and are we reaching everyone? So our Cuidando Su Corazón project here in San Antonio was focused in Rosenberg. I worked with one of the churches there, one of the priests, and he says, oh yes, come. He says, los casos delgaditos y al ratito están gorditos. He says, I married them thin, and then a little while later, they're a little on the chubby side. So he said, we need your intervention. Please come join us. And he was very supportive and gave lectures there, during Mass and so forth. But what we found out is sometimes when we focus on individual behaviors, there's a lot of things that can cause barriers for them. This was one of the workers. He was a construction worker, and he said, yes, I participated in our program. And he started changing his behaviors. His wife no longer packed him a bunch of tacos to take to work to give out to his friends, but had a much healthier sandwich for him to bring to work and so forth. And his friends, his colleagues were saying, oh, what's going on? You don't want to share your food with us anymore? So they gave him a hard time. His wife, who was also trying to lose weight, would go to her in-laws, and the mother-in-law would say, hey, have a second serving. And she goes, no, I'm really full. Oh, you don't like my food, So it's just like, it was really hard. So sometimes our Latino community wants to show love with food, but we're our own sabotagers, right? We're kind of sabotaging someone who's wanting to make a positive behavior change. So again, educating the community, educating the family members for change is so important. But things didn't stop there. And so we needed to start thinking, how can we maintain better change and reaching a larger number of individuals? And that's where Dr. McAllister from here, faculty here at the School of Public Health, came into my life. And he was all about reaching larger numbers. He had just come back from Finland, where they had control of the mass media. And Alfred was just one of those innovators and thinker that thought out of the box. The more I think about him and reflect on him, he was always like 10 years ahead. So I was fortunate to have been exposed to him. And as Dr. Fernandez said earlier, Dr. Albert Bandura was the crux of our work, really focusing on the social cognitive theory. And let me tell you, this has worked for a long time for me. Over the last years, I just keep innovating different ways to utilize this theory. And things have just, you know, I'm very thankful and grateful to the good Lord for the opportunities that I've had. But Alfred and I worked on a model that was called the diffusion acceleration model, you know, where we used media to put positive role models to make a behavior change. And then we had our community health workers that were out in the community reinforcing that information. And that led to a larger exposure of our information. And so instead of reaching just a small group and changing maybe one or two behaviors, hopefully we were beginning to change hundreds of behaviors. But it was a really intense model. We mapped out the community areas where our community health worker had to work. They would go by, they would tell us what grocery stores they were there, what convenience stores, what churches were there, and they networked on different types of opportunities. And we didn't ask them to go far. And I was talking to someone who was saying before they were volunteers, now, of course, we pay our community health workers, which was a great evolution. They should have been paid. These were knowledgeable women, primarily from the community, who wanted to do something for their community. So, and we told them that we just want you to go the next 2 to 3 blocks. They're your neighbors. Help us distribute this information. And so ideally, hopefully they were seeing our message on the radio or listening to the radio messages, hearing it on television, and also reading about it in the newspaper. And then their neighbor was bringing them a flyer about where the community resources were, where the hospital was, where the clinics, and what hours the clinics were open. And there was a little calendar of different types of community events that were going on, so that it was truly engaging. So then my next question and my opportunity to take this at a larger level was to have my first grant after graduating was from the National Cancer Institute to establish the National Hispanic Leadership Initiative on Cancer. So I said, can we take this model that was done in a small community and can we replicate it? So it's kind of like your implementation science, just about 20 years ahead. You know, so this what I did then, and I said, develop the first study to look at similarities and differences among our Latino population. So this study then led to Redes en Acción, and Dr. Fernandez was part of that study as well. We branched out into further communities. We had community advisory boards. We had specific elements that we wanted to train our community in. And what we found that, again, the more likely they were to follow the model, the more likely we were able to create change. And we were able to create change for cervical cancer. We got a number of women to come in for screening. But the other thing about Redes en Acción, it had 3 major components: a research component, a training of early career investigators, and a community education component. So always putting those elements together was really very rewarding in each of the sites. And the sites were selected by who they represented. Like Florida was predominantly Puerto Rican. I'm sorry, it was Cuban. New York was predominantly Puerto Rican. San Francisco was Central American, and then we compared Texas and San Diego with the different types of Mexican American populations. But together, our research network generated $230 million in cancer research with a Latino focus. So it was really rewarding to work with these investigators. And then from there, this research network lasted 20 years. We went from community-based work to find out what's going on in the clinics. And we found out that in the clinics, our women were not getting timely referrals for their breast or cervical cancer screening. So we introduced a lay patient navigator, not a nurse navigator, but a lay patient navigator. And we found out that having that navigator working within the clinic and following our patients, they were more likely to get a timely diagnosis and more likely to start treatment earlier than had they not had a patient navigator. So that was 5 years. I mean, really compared the difference. And the main thing was also language. The fact that our community health workers were bilingual made all the difference in the world. And then the next study that we worked on was really on survivorship. And we focused on breast, colon, and prostate cancer survivors, and also tailoring a patient navigation approach to see if we could help improve their quality of life as they went through having been diagnosed and surviving cancer. And so all of this, I have maintained a close collaboration with my different research colleagues. And in addition to doing our work, we also disseminated this information, and we started building a network of over 1,800 Latino cancer stakeholders that were interested in disseminating the health information that we had developed. We developed a booklet called Historias. It was just all on breast cancer. We're really talking how these women were resilient and how they took action so that they could be positive role models for others. In addition to that, we came up with different storylines to, okay, so everybody's busy trying to come up with all the excuses you get, right, when you're trying to help schedule them to come in for their appointments. I'm too busy. Well, get a calendar. Just like you do other things, make sure you put it is on your birthday that you're coming in for your screening. We talked about the importance of HPV and tried to overcome some of the barriers that some of our families feel about the HPV vaccine. And another one with men, trying to get them to go in for colon cancer screening. So, oh my God. So these are two men making a promise to their mother, yes, I'll go in for screening. We tried to appeal and bring in the cultural elements into all our messaging. And then we started one on clinical trials. Even before clinical trials, diversity was important. And this was a young man. He was a boxer. And he, the message line was, I'm fighting for my life. I'm not giving up. I'm signing up for a clinical trial. And we had 1-800 numbers directly to NCI's hotline for them to get the information that they needed. So it's been an amazing journey. I've really enjoyed working with everybody, but most of all, to see the own personal growth of each of my colleagues. With Dr. Perez Estables is now the director of the National Institute of Minority Health and Health Disparities at NIH. Dr. Greg Talavera is the leader of the study of Latinos. It's called SOUL, has just done a number of publications. They've mentored a lot of postdocs utilizing that data. Deborah Parra Medina started as a program coordinator for Redes en Acción. She got her doctoral degree, went on to South Carolina, came and worked with me for a few years, then went to Austin and is now in Colorado, leading her own Center for Health Equity at the University of Colorado. And then Frank and I have truly developed a wonderful research opportunity that I'll share more in just a minute. But he's also now the professor of psychology and medicine there at University of Miami, and is also the associate director for cancer survivorship. And not least, but Dr. Maria Fernandez was also one of our site leaders, and her position here as vice president for population health and implementation science. So it's really delightful to see the growth and the different where all these initial opportunities have led. But a lot of my work I could not have done without the support of our president, Dr. Bill Henrich, who recently passed away in May. He had his own cancer struggles, and one of the cancer transplants did not work for him. And so he left us unexpectedly. But he was critical. He was very responsive to the UT system. They had recently published a report that was called Code Red, and that there was need for more public health infrastructure in South Texas. And he recruited me from Baylor, said, Amelie, we need somebody to come and establish a Disparities Institute. And I said, I'm not about disparities, but I'm about promoting health. If you will allow me to call it the Institute for Health Promotion Research, modeled after what I had learned here in Houston, he said that would be fine. So he gave me that opportunity to start the center in 2006. It's still, because of funding levels, haven't been able to grow it as widely as I would like, but we've made a tremendous impact. And in our institute, we truly embody the public health message. It's really to try to find out what's going on upstream that's causing the problems downstream, and how can we make a difference. And in working with many of our physicians at the Cancer Center, he said, Amelie, what are we going to do? Why are we still treating metastatic cancers? Why are we seeing women come into the clinic with their tumor coming out of their chest? What can we do to truly make a difference? We need to do more. So that continues to inspire my work. And with support from the Robert Wood Johnson Foundation, we had the opportunity to start Salud America. And this now embodies what I learned from Dr. McAllister in terms of designing a network that truly informs and inspires advocates through a digital format, so that we can create more systems changes for social determinants of health, and to create more health equity, not only for Latinos, but for all. And our team develops very tailored content and stories and tools and actions to take this to the next level. We design and create Latino-focused content so that individuals reading that information, so that person looks like me, and perhaps I can make a change as well. Our network has grown to over 400,000. During COVID, it went up to 800,000. We became the go-to source for individuals looking for information impacting Latinos. This is kind of our network. It's nationwide. It's composed of community leaders, moms and dads, healthcare researchers, and school personnel. The larger the bubble is the higher, where we have the highest concentration of our social media work and dialogue with individuals reaching out to us. Our curation team really focuses on finding those real stories that, can truly make a difference, but not just stories. What did that person do to make a difference in their life that led them to make a behavior change? So we tailor that information to really create these steps that other individuals can take through crafting the messaging. And we don't have to worry too much about the words that we're using, because we are embodying the cultural influence that's being brought into the message by that individual. And then we connect them through our wide network of social media in terms of the web, email, and other social media engagements. These are the main content areas that we have been working on. The three broader areas are creating healthier neighborhoods and communities, helping create healthy families and schools, and then healthy, cohesive cultures. And then the bullets underneath are the subcontent content that we're constantly looking for. But many of you may recognize this theoretical model here in terms of the social cognitive theory from Albert Bandura. Is number one, the importance of self-efficacy, of being able to identify with the message that's being delivered to you. And he taught us about self-efficacy. How can we build a larger group of individuals who want to do something different? And it's that collective efficacy that is so important in our messaging. So we always have the three things working: peer modeling, so we can increase self-efficacy, and increasing collective efficacy. These are just some stories that I'll highlight and just go through very briefly. But here is Jorge Oliveira. He was just creating neighborhood gardens for growing fruits and vegetables and taking empty space and how he went about doing that. And so what we do is, again, we highlight him, but we develop the story that it has steps that if somebody wants to replicate that, they can do that in their community. This is also Minerva Perez, and she wanted to help people get rides to their health care because transportation barriers were hard. So she started a system and working with different groups to make sure that those patients could get to their health appointments. And I'll take a little bit of time here to share another role model story. This is John Hernandez. He used to be a coach at one of the schools in East Central San Antonio. And, you know, when he noticed that the kids weren't showing up for practice, he just didn't write them off. He took time to go to their home to find out what was going on. And what he found is some of these students couldn't make it to practice or couldn't make it to school because they were taking care of a family member, or they had to stay back to take care of their siblings while their parents went to work. So he went in to learn more. And then he said, you know what? I want to do something different to help these students so that they just don't get marked as being truancy or being absent from school and therefore not getting credit as school. He developed a program that really focused on identifying what was going on with those children and helping them, helping their teachers understand why were they not there. And so we created these action packs that other peoples could replicate, and we called it trauma-sensitive responsiveness. And so we showed how John was creating and working with his team of teachers within his own school, but how other schools could adapt this. And so we explored different ways of, taught people how to explore what was keeping their kids from coming to school. How to start your conversation, get draft emails that they could use to kind of start those conversations, how they could go about holding focus groups with the teachers to develop a support system for the children. And then most of all, also how to connect with community services that were there. As we promote our trauma kit, we've had over 900 downloads, and we follow individuals who download the information. We also make our curators kind of as coaches to see if they can assist the individual in making those changes in their community, and it's been really responsive. And then another program was called Handle with Care. We found this program out in Virginia, but it was not being shared or replicated in many states. So we approached one of the school districts in San Antonio to ask if they wanted to maybe take a look at this program. So we worked with Ms. Centeno and a police officer, and they talked about, yeah, that would be something that we feel that we could use here. This program was slightly different from the one that John developed. And in this case, if a child was going through an adverse event at home, a parent was picked up by the police, or some kind of abuse was happening in the house, and the police were alerted and they came. Sometimes that child came to school, but nobody knew why that child was acting out. So with this program, the police department would contact the school, so the school could then contact the social worker or the individuals in the school, and they could provide that child with a little bit more attention and loving care, or connect that child to some community resources to help support them, and not just assume that that child was acting out and was misbehaving, and so therefore should be expelled or should go to the principal's office. So again, just taking time to show a little bit more compassion and care. And so again, similar to the other program, we break it down into steps so that people can follow it and try to implement it. And this particular program has had over 14,000 downloads, and we've had 45 states that have actually gone and implemented this program in different schools. So we're really excited. This program here is just, again, this slide, are different types of action packs. We're constantly innovating and changing. After COVID, there was a big interest in racism as a public health crisis. So what could we do to help communities, motivate them and get them involved in this issue? And so we modeled what positive resolutions would look like, and people could download those resolutions, take it to their city council and ask, say, hey, we want this change here for San Antonio or in other communities. Another one was to get our new clinicians to think about their responsibility in fighting for social justice and taking an oath to further not just their medical responsibilities, but if they notice some kind of inequities going on, what should they be doing? And last is another school, started a school pantry. You know, we know that oftentimes our kids weren't opening packages and just throwing them away. Instead of just throwing them away, they were the cafeteria staff would pick them up, put them back in the refrigerator, and they would create brown bag lunches that kids could take home after school, because oftentimes our children didn't necessarily have another meal to eat after they ate at school. So these are just different ways that we've been trying to address and make a change for our Latino community. You say, well, are you sure this is working? Well, yeah, we surveyed our work, and we found that there was a strong relationship between the degree of engagement with our communications, people downloading, reading our material, and that the actions that it led to. And we were able to see and document specific differences going on at schools, at the local or state level, as well as the federal level. So the higher level of salud engagement, the higher the level of advocacy. And then we also did a multivariate analysis, and here what we found again, the higher the engagement that the individual had, both at the self-efficacy and collective efficacy, the more likely to create some advocacy actions. And Robert Wood Johnson on their own evaluated the extent of our program, and they were able to document that we were able to create policy changes that really were supportive of these different types of actions that we were promoting. So now it's just not enough to do things at the community level. We need to ask ourselves, where are we in representation at different levels of education? Many of our patients say, I only want to go see a physician if they're Latino. Well, we don't have that many Latino physicians. Here is a description of some of the statistics that less than 6% of our nurses are Hispanics, about 6% of our Latinos are doctors, well below their peers. And again, well below our representation in the demographics of 20%. So, you know, again, in terms of hospital leadership, there's only about 2% of Latinos are involved in hospital leadership, only 4% of the leadership in our medical schools. And then even the new enrolling applicants, and this just so happened to be the year of 20 to 21, less than 7% of our applicants to medical schools were Hispanic. So this really made me look at, in working with AACR, at the whole pipeline and what is happening with regards to Latinos going into the health professions. And you can see these dramatic numbers here where, you know, in terms of the white population, just getting into college, 57% compared to 19% for Hispanic, 14% for African American. Getting into some kind of a professional education enrollment program for Hispanics, 10%, 13% for African Americans. Getting into medical school, you see again the drops to 6 and 8%. So this is really concerning, and we hear discussion about, you know, K through 12 programs, getting more students involved in science and so forth, but we need to do so much more. So for me, it was like, where do we start? Where could we start with helping to address the pipeline issue? And I'm so excited that some of our Existo students are here today and actually working on their doctoral degree. I worked with my colleague, Rena Pasic, at UCSF, and she had developed a minority training program. And I said, Rena, I want to really develop something for Latinos. So I came up with a Latino focused, and I couldn't, because of the guidelines, you can't just make it for Latinos. but we made it for Latinos or anyone interested in working with the Latino population. So it was always inclusive. We never denied anybody who wanted to participate in the program. But just by the description, we had a large number of individuals who applied to our program. And the main components of this, again, the social cognitive theory had a very strong influence in our work. Every year, we recruited 20 to 25 Latinos nationwide. We brought them in for just 1 week to what we called a summer institute. And we really helped them validate their culture. You know, we brought a poet laureate in, Dr. Carmen Tafoya, to talk about, she says, you know, how oftentimes we suppress our culture. And just last night, we talked about it, where our parents didn't want us speaking Spanish because they didn't want us to appear different, or, you know, these kinds of things. And the whole thing was to assimilate. But we didn't realize that we weren't talking about some of these things openly. So she took our students through the different stages of your culture and how important it was to be able to identify with that. Our program also had internships for those who wanted to take advantage of it. We had 10 internships. They would identify a faculty member at their local institution that would be willing to monitor them so that they could beef up their resume as they apply to medical school, and then, or to a graduate program. And then we also had alumni support. Each team developed their own Facebook where they maintained communications. They now had a network that was nationwide. They had friends not only from their community, but in different locations across the US. And they became their own support team as well. So we trained over 226 Latinos who came through the program. Again, it was just a cohort of 20 to 25 each year over a 10-year period of time. I'm proud to say that 35% of them applied, enrolled, or graduated. And I'm still getting letters and said, Dr. Ramirez, you probably gave up on me, but I just applied and I just got accepted for my doctoral program. So these were individuals that were either still in a master's program or had just recently completed. So, you know, they had to apply, they had to get in, they're 4 or 5 years. So the numbers are still coming, and I'm hoping that the stats will increase. And those of you who have already gone through it, please continue to fill out those surveys. We need you, the data to hopefully come up with a new plan in enrolling. And this program was just so effective. In 1 week, we exposed them to positive role models, Latinos that were doing, you know, research throughout the country. We brought them in. We brought them individuals to talk about where to find the money, how to decide what program you wanted to apply for, how to find a potential mentor at those institutions. We broke down all of these steps, and each of the days had a different element to it. These are just some of our success stories. Rosalie now graduated with a PhD in translational science, and she has now gone into working in oral health disparities at the dental school. This is Nicolas Acuna. He was from Arizona, and he is now a postdoc scientist at CEDAR, at the Cancer Center at Cedars-Sinai. So we're just excited for him. And then Malawi now is an assistant professor at California State University, and again, leading her own Center for Latino Health Evaluation and Leadership Training. And then Roger kind of just knocked it out of the park. We're really excited for Roger. Roger was originally from Puerto Rico, got his undergraduate degree at UTSA, and then went on to get an MPH and a PhD from the University of Illinois. He got a postdoc at Harvard, got married, and has his own research lab at Columbia. And he calls it the FIG lab because it was Roger Figueroa. And so his FIG lab starts with the Figueroa Interdisciplinary Group. And just so good to see him, you know, do some amazing work. So again, we didn't just stop there, you know, in putting a spotlight and trying to fill the gap, but we also moved into how can we help our research volunteers themselves and to really diversify research participation. Right now, the pharma industry is very interested in diversifying clinical trials. FDA passed a ruling that now they have to do more of that. When we looked into it, again, early back in the day, but now more so, less than 4% of Latinos participate in any of the FDA clinical trials because of the barriers of lack of awareness, lack of knowledge about the disease, again, literacy issues, travel, cost, insurance, and so forth. And then in terms of enablers, do they trust their doctor? Who's really offering them the trial? Are they feeling that joining a trial will maybe give them a hope? They do understand that. And having clear information and encouragement for the family were enablers for them to maybe make a positive decision if they would participate in a trial or not. But these are now groups are coming to us because of Salud America and asking for our help to recruit more Latinos into the clinical trials. And so they're contracting with us, and all of us contracted with us as Amelie, will you help us? We're supposed to reach, 1 million individuals, but right now we have very low Hispanic or Latino representations. So we took a multiple approach, not only doing health fairs, but also conducting webinars and disseminating information through Salud America. And we just got a number of clicks and impressions of people reading about what all of us was all about. And going back, as I said, maintaining that level of education is so critical on all our different areas. We also had a group from Colorado that reached out to us who had developed a low-grade glioma registry, and they were not recruiting Latinos. Says, Amelie, we'd like your help. Can we contract with you? And so this is a different way for me to, our Salud America, even though it's a communications platform, it's really difficult for me to get sustained funding for them, right? So this has been a way to really maintain our team. And Genentech came to us and also asked us for help, and they had a health equity grant that I applied for. And so we developed a multi-level intervention program to help make more informed decision-making about clinical trials. We had different levels for this information. The first was at the national level through Salud America, really promoting bicultural multimedia content on clinical trials and the importance of collection of biospecimens. We use role model stories, again, keeping the same theoretical framework throughout our work. We also promoted local trials that were available that individuals could sign up for. And most of all, continue to uplift stories of individuals and positive role models that had actually participated in a clinical trial. The other thing, though, that we worked on is that oftentimes the lack of trial participation is just not because the individual didn't want to participate, but clinicians making the decision not to offer them a trial and said, nah, they don't have transportation, they won't finish the study. They require someone who is bilingual. They don't have the insurance to cover the first preliminary tests that they need. So we developed an action pack that was called implicit bias. And to get clinicians to really think about, are you maybe holding back and not doing a good job at promoting and recruiting a diverse representation for your clinical trials? And again, we've had over 800 individuals download, take the test, and making some positive changes. We also, at a national level, did several webinars with different organizational groups to talk about, how to encourage Latinos to participate in a trial, how to overcome some of the implicit bias that they might be exposed to in their clinics, why they should think about participating in a trial, and just looking at many of the myths and misconceptions about participating in a trial. So all of this aired over a period of time. So that was the national level. Then locally, we did a randomized trial in the clinics. We actually sent patient navigators to start talking about clinical trials at the clinic while the patient was waiting to see the doctor. And they were exposed to a video, a low literacy booklet, and then also offered patient navigation support. We're just now analyzing the data. We just completed this particular study a couple of weeks ago. And then we also did a similar format, but out in the community. So this was then going to community groups and sharing with them the importance of clinical trials. And when we tried this the first time, if you don't have cancer and talking about clinical trials, it's really hard to assimilate. Why do I need this information now? Why should I be concerned with it? So what we try to tell them, you never know, but there may be a family member who has it, who will develop cancer, and you might be asked these questions. So this is why it's important to understand. So at the community level, we did just more pre and post testing. They were exposed to a PowerPoint that was shared with our community health worker and our patient navigator, and they were available there to answer the questions. And these particular study, I've been working very closely with Dr. Patricia Chalela, which I shared earlier, was from Colombia, and she's been with me for over 20 years. She started here as got her master's here. I facilitated her through a Fulbright grant that she had, and so she's just now her own independent investigator, as an associate professor with us at the Health Science Center. So I was really glad to see how well she's developed. So then from just not only trying to increase the diversity in clinical trials, but we also need to start thinking about our cancer survivors and our patient advocates. So we hear our patient advocates, but you know what? They've never received any education about how can I help promote studies among the Latino population. So this past year at our Advancing the Science of Cancer in Latinos conference, we had the first advocacy training program that was held 2 days in advance of the conference itself. And it was led by Barbara Segata from Puerto Rico and Sandy Stanford from the Alamo Breast Cancer Foundation in San Antonio. And they are very active patient advocates at SWOG trials, at AACR, at Komen. But when they asked, would you know of any other Latinas that we could bring into this, they didn't have anybody to pull from. So we specifically developed this educational program for them, again, exposed them, taught them about the science, what types of things are the kinds of questions that they could look at. And our advocates were just so thrilled, you know, to have this information and say, now we can speak and we can present our concerns or our arguments a little bit more in an articulate fashion, and so that we can contribute to improving patient care and patient experiences. And you'll notice how young some of these patients are, and that's really concerning, you know, of them having been diagnosed with cancer at such an earlier stage. This is Mrs. Portillo. Again, she says, I was a bit submissive and the doctor was always right, but now I feel like I have the knowledge and the courage to kind of ask for questions and advocate for my own health. And then this is Rosemary Carrera, also a breast cancer survivor from Miami. And she just found that, again, that the training was the most efficient way to get the most recent scientific information so that, again, they could take a more active role in their own health care. So these are things that, you know, that are the full gamut of everybody that we're trying to reach, either in the community, at a national level, professionals as well in the future pipeline. And right now, I just wanted to share, I'm really excited about the cancer survivorship work that we're doing. We know that cancer survivors are more likely, Latino cancer survivors have poorer outcomes, tend to have lower education levels, have no insurance, no primary care available to them. And so therefore, they're more likely to have, you know, later stage cancers, worse treatment outcomes, and lower survival rates. But we know very little about their health-related quality of life. So we just recently got funded to conduct the first study on Latinos, the first EPI study on Latinos cancer survivorship. And this brings back my colleague, Frank Benedo, who reached out to me, says, Amelie, can we work together? And that grant, when we pulled it together, it was truly fascinating because it was a story we could tell. We had already worked, we didn't have to fabricate that we hadn't worked together. We had publications together. We had everything. So it was really been a great, so it's a multi-PI study, and we're doing some great work. The hardest thing, each one of us is to recruit 1,500 cancer survivors, 1,500 from the South Texas area, 1,500 from the Miami area, and we'll establish the first Hispanic cohort. We're going to want to look at multiple determinants of symptom burden and health-related quality of life. We want to look at some of the psychosocial mediators as well as the biological mechanisms that are going on within our population, and then also to explore potential moderators. But the sad thing has been that many of our, as we screened the cancer survivors, many of them were being disqualified because their cancer had metastasized. So again, what does that tell you? They're coming in so late that it has reoccurred. And so we just went back to NCI and said, can we change it? Since so many people are living with metastatic cancer now, if we could expand that criteria. We developed a pretty fancy dashboard, keeping track of all our numbers, how many people are coming in. And so we're doing good in terms of recruitment. We're doing good in terms of the diversity. You know, where we're having trouble, and I'll show you in just a minute, is we're not at where we need to be. We're only at about 70% of our rate right now of accrual. San Antonio got started a little later because we wanted to make sure we had all the processes defined before we implemented in San Antonio. We have great retention rates. They're coming, it's a 6-year study, so they're coming in yearly. What we're seeing though is we've had difficulty in recruiting for liver, stomach cancer and lung cancer because these patients have been pretty ill. But as I said, gender-wise, we're pretty good. Our Hispanic breast cancer survivors have been amazing. Males with prostate cancer, you know, or colon cancer have been pretty cooperative. But you can see our ethnic origin distribution has also been pretty good as well. We still have a combination of English and Spanish preference for the population that we're interviewing. In some, you know, the language they spoke as a child was only Spanish. So again, when you go back and want to describe your symptoms and the care, most of them revert back to their Spanish language, which our survey is already 4 hours. So it goes a little longer when we do it in Spanish because they really want to share their story with us. So we're looking forward to this study really giving important data for the next planning phases of looking at secondary and tertiary prevention within our group. But I did want to just share, I know I'm getting at time here, a few comments given to us by our cancer survivors. And they said, thank you. Thank you. This is the first time anybody has wanted to listen to my story. This is the first time I'm sharing my journey with anyone. And so it was really heartbreaking, and you know, to hear that and to know that our team has become such a caring team, that this is something that has truly made an impact on them. So, you know,
I was so excited to tell my mom about it. The fact that they're willing to just listen, I really feel like I can connect with the people that I've encountered with the study.
So, oops, I don't know what happened there. But anyway, she really showed the passion of saying, you know, somebody took the time to listen to what I had to say. And all I'm saying is to all of you is it's never too late to take risks and to try something new. And so I'm really proud of what Amber has done and shared with us. And I wanted to share with you a little bit that got me out of my box. And I took a trip with my son this summer, and we went to the Utah Olympics Training Center for bobsleds. And I got on a bobsled and I went down 90 miles an hour. And so just wanted to share as my granddaughter watching on. There goes the bobsled. It was really a lot of fun. I came out, I think, with a few less brain cells, but your head really does go back and forth there. But it was a fun adventure just to kind of get out of your box. So always find time to have fun within what you're doing. In terms of future research, oh my God, the opportunities and avenues are there. It's for you to explore and try to really, again, bring in your passion with what you want to do and what areas you'd like to go in. But we certainly need a lot more work in social determinants of health. And I still feel for prevention, there's just not enough, right? But where do our resources go? They go into treatment. So again, we need to advocate for more dollars to be placed into prevention so we can do more. And we certainly need to do more in diversifying our clinical trials. And this is, again, what led me to develop the Advancing the Science of Cancer in Latinos Conference. We had the first one in 2018, we're planning one for 2026. But to bring us all Latinos together to really talk about what are the issues, where can we make a difference, and to show one another. When we go to conferences, you can really count the number of Latinos that are there at these conferences, or to find an abstract or a poster. So here we're trying to bring everybody together to truly share that information. So mark your calendars for February 2026 and come to San Antonio. And again, explore new ways to research and document the impact of social media. I think it's we have to do more to building trust within our community, and thinking of new ways that we can use it to create action. And most of all, if you see someone that has an implicit bias, don't hang back. Just really think about what we need to do to reduce those biases. And then there's also a group that's called the Collaborative for Anti-Racism and Equity, called the CARE Group. San Antonio is part of that. And so if you're interested in learning more about them, we encourage you to sign up and be there. And then one of the great things that we've developed as part of Salud America is a health equity report card. This takes national data, and all you need to do is put in your zip code, and you can download how things look in your community with regards to all these drivers of health that are bulleted here on the left-hand side. And what some small groups are using is downloading that, using it for grant writing, or making a case with their city councils and say, we have food insecurity issues here. We want to change that. And here's the data, just to, again, stimulate discussion, and that discussion can lead to, potential behavior change. So in the end, for me, this has been a very personal journey. And the goal of your work is not to start something, but how can we end something? So you need to be passionate. Nobody's going to hand it to you in a silver platter. You need to think of ways of how you're going to fund it, who you're going to want to work with. And for me, helping shine a light on Salud heroes who have truly made a difference that can stimulate change and change inequities has been important. And again, this is a lesson I learned here at the School of Public Health through Dr. McAllister. So if we can build trust and to get our community come in for screening, or we can detect cancer at an earlier stage versus a later stage, or to help encourage more Latinos to go into medicine or public health, we have a larger team, right? We have a group to work with. So when it's time for me to leave my job or to this planet, I want to make sure that it mattered. And I really try to get the word out, to work in different ways. And most of all, to remember Ernesto, to remember Amber, to remember individuals such as Roger, who's making a difference. And not only to do it for them, but to do it for your families. And these are my grandchildren, and I want them to have a brighter future as well. And I need to thank my team. Our study participants have been amazing, and my team at the Institute and at the school have also been very rewarding to work with them. So thank you all. And again, I'm extremely humbled to have received the McGovern Award. Mil gracias por todo. Thank you.
Thank you so much, Amelie. All I can say is, wow, you rock. You are the queen of Latino health. And, seeing the examples of where you've seen gaps, right, in training and policy and behavior, and then managed to create this just phenomenal program that has had tremendous impact over the years is incredibly inspiring. I'm wondering if there's, I know we're a little over time, and we do have lunch for folks that are here. If anybody has any sort of burning questions, we can take those now.
Have you had any cross collaborations between you as Latinos and Latinos in Latin America, where you can see difference, divergence trends in terms of health disparities with those who are here and those there?
You know, we don't have any formal collaborations. I think Dr. Fernandez has several of them. But what we have found is that once they're here, you know, and looking at the similarities and differences, you know, sometimes they felt more supported in their healthcare, you know, in the country that they came from than here in the United States. And so sometimes we've created more barriers, you know, for them. And so I would think that that would be the biggest difference, because again, more than likely they have a provider that speaks like them, that looks like them, that they have a support system, you know, all of those things that are individuals who've come here to live in the United States, you know, may not have. So, yeah.
I will say that, you know, just seeing this amazing set of materials and experiences, I think that there's a lot of opportunities for building bridges and learning from what you've done here, Amelie, with you know, people in other
Yes,
countries.
definitely. And we're opening and open to that. And that's where the conference has really come in. We're trying to make it more international, you know. So if you know of anybody, send them my way. Yes.
All right, thanks everybody, and please join us just across the patio there. Have lunch.
Thank you. Thank you for making time and for staying throughout. Thank you so much. Thank you to the audience, virtual audience as well. Thank you.